Hello everyone, welcome to the Careers 360 NEET PG interview series. Today we will be exploring about one of the most popular and challenging branches, which is general surgery. And to help us understand this better, we have Dr. Chetan Anand with us. We will talk about the scope, the specialities, how should aspirants choose a college, and some other important details which will be important for the upcoming NEET PG aspirants. So, Dr. Chetan, thank you so much for joining us today, and let's begin with your journey. Our very first question would be, what are the biggest advantages and challenges of general surgery as a career?
The advantages are a lot. I myself, being a general surgeon, would vouch for the fact that it has got immense satisfaction when you treat patients. Challenges, as every doctor would tell you, it is a very challenging field. Not only general surgery as such, you take any field, be it obstetric gynecology, be it being a physician, be it an ophthalmologist, any clinical specialty, and for that matter, even paraclinical and preclinical specialties come with their own set of challenges. General surgery, however, one of my favorite quotes to my postgraduates is that a surgeon is a physician first. Now, what do we mean by that? Surgery is not only about cutting. It is knowing when not to cut. It is knowing what the indications, what the contraindications. Every action of yours will have a consequence for the patient, either a good consequence or something that's detrimental. So always in the field of medicine, we always keep teaching our students and our fellow brethren about the fact that you have to adhere to primum non nocere. And what does that mean? That's the first principle of medical ethics. It says, first, do no harm. You may not end up doing good, but your first responsibility is not to do harm. While general surgery, surgery but the other name suggests it involves manipulating the tissues under anesthesia, or sometimes even, uh, you know, other forms of regional or general or local anesthesia. The fact is, you're going to manipulate tissues. You have a fall, you have a cut, and that is painful. Here, you're doing a willing cut on a patient. So you have to be more responsible. So I would say the advantages is it gives you immense satisfaction when you treat a patient, he goes back and he heals, and you're happy for the patient. The patient is happy that he has been cured of his ailment. And the disadvantages, I wouldn't say there's a disadvantage to it, but it's just that you have to put in long hours of work. You need to train yourself to be a physician and then become a surgeon. So you need to know how to have your, for example, correct your acidosis, correct your electrolytes, talk about nutrition of the patient, while at the same time also know how to acquire the skills and the acumen and the empathy of being a surgeon. So it's both more of a psychomotor skill that you have to develop being a general surgeon.
Thank you so much for explaining it very nicely. What qualities or skills are most important for someone to succeed in this branch?
Well, this branch, it is andragogy. We keep saying we teach adults how to become surgeons. They're adults, they know what surgery entails because they've already cleared their basic MBBS. While you're exposed more to the medical side of treating or diagnosing or evaluating a patient, when you come out to general surgery, a little bit of a shock because you don't do much of surgical handiworks in being MBBS. When you come over to general surgery, you first and foremost have to be willing to learn. You cannot teach somebody who's not willing to learn, who's not willing to put in the hours required. And as you know, it is a specialty where skill is paramount, and skill is not inbred. It is somebody's not born with skill. You may be good at a few things, but those things need to be honed over a period of time. And if you have the right person to be your mentor or guide, or that mentor guide need not necessarily be your teacher. It's a set of people around you who tell you this is a particular way to do it. This is a particular principles of doing things. Once you know that, then it becomes a lot more important and a lot more effective.
Our next question would be, when choosing a medical college for surgery, what factors should students focus on the most? For example, should they look for caseload, patient diversity, faculty, or surgical exposure?
Right. When I was doing my general surgery residency, and prior to taking this up, this was the most common question. Now I've got this particular rank. What am I going to get? Now you have a set of 5 to 10 colleges that you may probably target, and you may be getting that. The next question is, which among these should I take? How do I decide? So now, at this point in my career, I would actually say the only thing that you need to know is taking up a career in general surgery. So pick a college where surgery is done. Now, what do I mean by that? Every department in our country that runs a program of general surgery will obviously be doing a few surgeries. Now, you need to know what are the types of surgeries? What are the number of these surgeries? Do they have emergency patients? How many emergency patients do they operate? If there is an operating team and the number of surgeries are good, are they doing a variety of surgeries? Are they doing open procedures? Are they doing laparoscopic procedures? Are they doing procedures under local or regional anesthesia? What are the ancillary departments? For example, if you do not have a good department or well-staffed department of anesthesia, most of your elective long duration surgeries are not being done. If you do not have a surgical ICU or for that matter, any other ICU where post-op recovery for those patients who undergone a major surgery, how are you going to see? Always the learning dictum as a surgeon, I always keep telling my postgraduates is read, see, assist, do. So you need to, for you to become a good general surgeon, or for that matter, any specialty, you need to read, you need to have the knowledge. That knowledge has to be provided by you. And usually the andragogy principles of adult learning is you have to be willing to be learning that. So these days, a lot of resources are available, both offline and online, which are curated for the students of general surgery. If you have a good library, these are available these days on your mobile devices, on your tabs, on your laptops. So first, you have to be have resources available for reading. Secondly, you should be seeing cases. Now, again, seeing a whole lot of cases. If you go to any of the conferences, you'll see a whole lot of video, sometimes live demonstration of procedures. But that is how many conferences are going to attend in a year? Probably 2. So on a week-to-week basis, you should at least be able to see 3 to 4 good quality surgeries being performed. And with that forms the bedrock of seeing. The next stage is assisting. If you have a college where you have 30 postgraduate students, if you have 30 postgraduate students, does the college have enough number of patients, enough number of teachers? Well, yeah, these teachers are very important. Do they have enough teachers who are willing to teach their students? If I have 10 students and I have only one OT in a week, am I going to teach all 10? So I need to have enough number of cases and variety of cases for the teacher. And I need to have a teacher also who is going to be moderating my learning. That is called assisting. Am I going to get an opportunity to assist, or is it only the final year or the senior resident or the assistant professor or a lecturer who's always assisting the senior surgeon? They are going to learn. So in the entire 3 years, am I going to get to assist? And then the most important thing, am I going to do cases? Am I going to do cases under supervision? One. Am I going to be allowed to do some cases independently? 2. So this is how you need to see whether I'm going to have books. Now, I think that's universal. Every college is going to have a good library. Otherwise, also, I think students these days have online access to all most of the surgical textbooks and journals. So that is a pretty easy question. Every college is going to have this. See if you're going to be allowed to see. It is not that the first year resident is always there in the ward or in the casualty or trauma working up the cases. Are they allowed to go into the operation theater? I mean, seeing can happen in the wards also. Is there a daily rounds taken, which is teaching rounds? You know, does the unit chief, the next in command, does the assistant professor, associate professor, professor come and take you and ask you questions and tell you the answers? Do they moderate your learning? Do they guide you? If you're doing something wrong, is somebody there at hand to tell you? If you do not know, let us say you do not know how to put a central line, is there somebody to tell you, okay, come, I am going to teach you how to put a central line? Now, here it need not be necessary that your head of the department is going to come and teach you how to put a central line. It may be your assistant professor, it may be a lecturer, it may be a senior resident, it may be your second year resident. So how am I going to see these things happen? Am I going to see a hepatectomy? Am I going to see a mobilization of the colon in the first year? Only when I see will I understand why a particular thing is happening. Third, as I said, is only assisting. Just reading and seeing will not help. If that were sufficient, you need not have a department of surgery. You could get a what do we call as part of online courses for surgery, correspondence courses for surgery. So surgery is one specialty where you need to assist. You need to get a feel of the tissue. You need to know how much of traction to be given. You need to know which anatomical structure is in which place. When do I cut? How much do I cut? How do I sew? I need to know how to sew. I need to know how to do it open. I need to know how to do it laparoscopically. Right? And then I need to do them at first with my teacher or with my senior resident or my senior standing with me, guiding me every step. Secondly, allowing me to do it. And finally, telling you go ahead and do it. I'm right behind you. So this is the culture that you want to see in a college. Now, most of our Indian colleges have this culture. It's only students are not aware. All they go and ask, this is a very common reference, cutting chances hai kya? But this is what cutting chances means. You are doing it. But before doing, there are a few more steps and technicalities that you need to be confident in. Some of the colleges now in India have very good simulation setups. So before you go and put a spinal needle, you know how to do it. Before you go and put a Foley's, you know, on a simulator, you're putting a Foley's. Before you go and do an examination, there's simulators for part examination that can be used. There's simulator for operation room theaters now, where you can go and do. Do they have a cadaveric lab? If they have cadaveric lab, well and good, that can be used. So a student, what they need to research is not the name of the college or how big the college is. What they need to go and see, how many surgeries are being done. What are different types? Let's just go last 1 month, see how many, or the last 1 week, see how many emergency surgeries in the night has happened. That'll give you a fair idea. See last 1 week, what are the types, or last 1 month, what are types of surgery that they've done. Compare, if you have to compare 5 colleges, compare them on these parameters. Talk. You need to go and talk to, most importantly, the first years there. You know, how is the work culture? I mean, I've always heard this, and this is in a very wrong manner, that people tell, that's a very toxic work culture. It is not a toxic work culture. The work culture is just strict. There are certain expectations of you, and you have to fulfill them. You are expected to be in the ward at 7 o'clock, finish off the works at 8 o'clock, be ready for rounds at 9 o'clock. Now, that is not toxic culture. So that is what you need to just keep a view about. Right? And then finally, whether you get to do a chance, cutting or not. So running behind cutting is not the answer. See what happens before cutting also.
So, doctor, our next question is, how important is the availability of modern surgical equipments in a hospital for residents training? For example, facilities like laparoscopy towers, robotic surgery, or advanced OTs. Should students give high weightage to these factors while choosing a college?
I mean, I answered this partly in your previous question, but I'll take this again. Now, you need the basic infrastructure and probably a little advanced infrastructure. Now, not every college will not have a robo. So what do? You don't take that college that does not have a robo. And even if they have a robo, are you going to, as a resident in the first or second year, to work on the robo? Are you going to operate on the robo? No. What is it that you need to see in the first and second year and third year of surgery? Basic principles of surgery. See, look at the number of cases that is happening. Look at the number of cases that the first year, second year, third year residents are doing independently at the end of it. Right? See with the variety of cases. Definitely have a look that whether laparoscopic setup is there or not, and whether the laparoscopic setup is available in the emergency or not. For example, if you have a laparoscopic setup in the emergency, only then I'm going to emergency lab procedures. Correct. Now, robo is not mandatory. Simulation is not mandatory. These are factors that if you have, it enhances the learning of the students. right? So I would say choose a good college that teaches you, that gives you the opportunity to see and learn and do and learn. That is what you need right now. And by the time you're in your third year, anyway, the college that you are interested in has one laparoscopy, they'll already have 2 or 3, another 2 years' time. All the colleges are going to upgrade themselves, are already upgraded. So do not get stuck on technicalities. In that way, you'll never go to a tier 2, tier 3 college, tier 2, tier 3 city, where the colleges may be good, the teachers may be good, but they don't have a robotic setup. So are you going to say, no, I'm not going to go because they don't have a robo? So I think go to colleges where they want to teach you basics of general surgery well. They're going to allow you to do the basic surgical procedures well, and you come out as a confident surgeon. And surgery is not about 3 years. Surgery is about 30 years. You keep learning, you keep learning. I'm telling you about surgery, but every specialty in medicine is the same. You keep learning, you keep upgrading yourself. When I was doing general surgery, laparoscopy was not all that well entrenched. We just had 2 sets. So the residents would never get to do it. It was only be the consultants who would do it. But now in my institute, my postgraduates are doing uh, laparoscopy procedures. So first they're seeing, they're reading, they're saying, they're assisting, and then probably at the end of second year or third year, we're allowing them to do certain laparoscopy procedures also. So don't get stuck on the fact that robo is not there, simulation is not there, cadaveric dissection tables are not there. If surgery is happening, good variety of cases happening, if the faculty is good, and you get taught, if there's a good academic program. Now that is also important. It is not only infrastructure, it's a program that's important. You should be having a good, well-run academic program.
I'm sure this explanation of yours is going to help many other aspirants make an informed decision. So, with this, our next question would be, how should students think about the difference between MS and DNB in surgery?
Well, the endpoint is the same, isn't it? Whether you do MS, whether you do DNB, you're going to turn it to be a surgeon. It's recognized by the Medical Council, NMC now. It's recognized in India. A DNB surgery is also a surgeon. A MS surgery is also a surgeon. So where is the difference? The difference is in the minds of people. I've had residents who are both. Some done MS, somebody has done DNB, and they're good, equally good. It is at the individual level. I've had some DNB residents who are far better than my MS residents. And I've had the other way also. Their MS residents are far better than a DNB resident. So that does not mean there's difference in the program. It just means how they've been trained. If somebody does DNB from, let us say, a center that does whole lot of procedure laparoscopically, so they're going to be good laparoscopically because they've seen, as I said, no, read, see, assist, do. Whereas a person from a tier 3 government medical college will be very proficient in doing all open surgeries. So you cannot compare the two. They are very good. Both are very good. Should not have a difference. And these days, the post MS or post DNB, there are a lot of subspecialties that you can get into. And eventually, it's the way you want to practice. Do you want to be an academic surgeon? Do you want to be a surgeon who has his own practice? Or you want to become an entrepreneur and run your own hospital? It all depends on what your factors are. But as such, DNB surgery and MS surgery, the only factors probably some of the MS colleges there from a very long time, and they have a set academic pattern and they've been time tested. Whereas a few DNB institutes may not be as good in terms of the time that they've been there, but the output has been equally good. So I don't think if you want to operate, if you want to do well for the patient, DNB surgery or MS surgery should not matter.
What are the career prospects and earning opportunities after completing MS in surgery?
Okay, first of all, doctors need to eat, don't they? So the only difficulty in general surgery is you need to be in an institute for some time. You cannot just open up a clinic and sit there, and you need to operate. So you need to have an operating setup. So until you have some amount set aside for either joining in a setup which has an operation theater or have your own. So that probably will take some time compared to a non-surgical specialty where probably you could have a clinic of your own or sit in a clinic somewhere else and talk to them. So that is the only thing. Otherwise, career-wise, I mean, surgeons, as I said, surgeons are physicians first, and then they become a surgeon. So you're doing a physician's work, even as a resident, even as a surgeon, and then you go on to become surgeon also, right? So that should answer the prospect wise. And there are a lot of subspecialties now that people are getting into after general surgery, which is good, which is good for the patient that they get seen by a subspecialist or what we call a super specialty. But that is another 3 years of training, or in some cases, it is after MS 6 years of super specialty courses. So either way, it is good. Prospects are always nice to be in general surgery. Learning curve is a little more. I'll vouch for general surgery because 3 years is what you come out with the principles of surgery. Now, how you innovate, how you adapt to newer technologies, newer methods, newer techniques will take some learning. And if you pass your general surgery and be with a good mentor, then that path becomes smoother. But if you're on your own and lost, it might take some time before you find your own path. So that way, I think surgery has a little more longer curve and probably a little more time to settle down. But definitely, uh, just because it's going to take a longer time to settle down does not mean you will not settle. It's just a little longer. And many people are doing well as general surgeons also. And as I mean, we don't have a retirement age, do we? So all doctors keep practicing until the time they are ready to give it up.
Our last question is, how tough is the work-life balance in general surgery compared to the other branches?
Yeah, I wouldn't know about other branches. I would talk about general surgery. It is difficult. I mean, it's. I mean, how do you ignore a patient? If a patient is in pain, even on a holiday, even on days like Diwali and Holi, where mishaps do happen on a festival, you cannot say it's a festival. I'm not going to come and treat you. All the more if you are in your own private setup, private practice, where availability is seen as a very important criteria. If you're in a government institute, that does not mean you're not going to be available. You still have to go and treat your patients. Complications are part and parcel of general surgery, and you need to learn how to handle these complications also. You operate today, tomorrow you see a whole lot of complications. You need to go and tend to that patient. So for a doctor person, especially for a general surgeon, uh, work-life balance is tough. You have your family. I mean, there's only 24 hours to a day. So you need to give it to your patients. You need to give some to yourself, some to your family, some for social gatherings. And more so, I think it's there for every specialty because general surgery takes a little longer time. I mean, you need to operate. A complication, you need to operate. You need to have the time and resource and uh, empathy to do these things. And if you want, just for an example, if you want to take a 5-day break, you're going to plan it for in a month in advance. So I'm going to say 10 days before my break, I am going to have another colleague of mine ready to take over from me when I'm going on a break. So I want to keep my colleague in the loop, saying, I'm going to go on a break from this date to this date. I have admitted this, I have operated this. Can you take care of these patients for me? When I am on leave? And it's a reciprocal thing. When my colleague goes on leave, I take care of his cases. So it just requires a lot of planning. It is not difficult, just a little more planning. And I think by the time surgeons in the trained is 3 years, they have a good idea about work-life balance. And it's fun. It is really fun. You have a whole lot of your colleagues. You spend your day in and day out in the hospital. You start enjoying surgeries. And if you don't enjoy something that you do, you're always going to keep saying, even if I give you a whole day off, if I get a whole day off and I don't like surgery, I'm not going to recuperate mentally and physically. You've got to be liking it. You want to be going back to your hospital. You want to be going back to your patients. You want to be going back to your operation theaters and say, okay, today we are ready, let's go on. So there's no Monday in surgery. And there's no thank God it's Friday in surgery. Every day is an operating day. Every day is a patient taking care day. And yes, you have your times. At 24 hours, you're going to be asked to work. But your training in 3 years is going to teach you how to manage your work-life balance, how to become more resilient, how to become strong physically and mentally. So surgery is good.
Thank you so much, Dr. Chetan, for
Yeah.
sharing such valuable insights and for taking out your time for this interview. I'm sure that many NEET PG aspirants who are confused about surgery as a branch will find this very useful and very helpful to decide and to make an informed decision. So, thank you so much for joining us today.
Yeah. Pleased to be here. Thank you so much.
See you in the next episode of Careers 360 NEET PG interview series. And to all the viewers, if you are exploring different branches after NEET PG, don't miss out the other interviews. We will be covering all the other branches as well. See you in the next episode.